Hello. This presentation is a quality evaluation of the UAB Medicine 2022 Community Health Needs Assessment. This evaluation was done by Kelly Banco, Ross Jacobson, Daniel Mami, and Leanna Roberts. In this presentation, we'll review a brief background of UAB Medicine, provide an overview of the CHNA using a 16-point evaluation criteria list, review the types of data used, and determine if there were any additional sources that would have been beneficial throughout this process. We'll then do a comprehensive review of two of the selected priority areas and offer some additional evidence-based strategies that may help UAB meet its goals in the future. UAB Medicine is an academic medical center located in Birmingham, Alabama. The health system is a Level 1 trauma center comprised of multiple hospitals, specialty clinics, a rehabilitation center, a women and children's center, a radiation clinic, and many primary care offices. It serves Jefferson County and surrounding areas, providing healthcare to more than 1.6 million patients annually. A community health needs assessment, referred to as CHNA from here on out, is a report created every 3 years as part of an Affordable Care Act requirement for all not-for-profit hospitals. UAB Medicine partnered with multiple stakeholders to collect data and insight on Jefferson County and use that information to develop an implementation strategy to address the areas of need. Let's move into the evaluation criteria overview. Using literature that focuses on public health planning and IRS requirement evaluation, a 16-point evaluation criteria list was located, which allowed for a systematic review of the CHNA. Each of these 16 areas were evaluated independently and assigned a ranking of high, medium, and low based on the quality of the information provided and the amount of detail included in the CHNA. As we proceed through the presentation, we'll provide a ranking of each area along with justification of why that ranking was assigned. The initial criteria review focuses on some introductory aspects of the CHNA. Each of these areas received a ranking of high quality. UAB addressed their method of defining community early on by explaining that they serve Jefferson County and the surrounding areas, but they opted to use Jefferson County only for the identified community because there was readily available community health data. The included information expands on the county's size, population, and geographic indicators such as urban versus rural. Demographic information provides racial and ethnic makeup of the community as well as social determinant of health data. UAB also provided a comprehensive list of health system and community groups, as well as including members of the public as part of the assessment and decision making. Specific groups surveyed include Greater Birmingham Project Access, local federally qualified health centers, the Catholic Diocese of Birmingham, Central Alabama Fire Chiefs, Forge Breast Cancer Survivor Center, the Jefferson County Department of Health, local community colleges, churches, medical staff members, the St. Vincent's Foundation, and the Firehouse Shelter. This all-inclusive strategy is likely to improve the efficacy of health interventions and, as a result, health outcomes. There was indication of significant time and resource contributions from UAB Medicine for completion of the CHNA, along with the promise to provide staffing and financial requirements for ongoing implementation strategy requirements. UAB included a cataloged list of community resources and healthcare facilities that are available to meet the full range of needs of a population. They also included targeted resources for each prioritized area of need. UAB Medicine's process of approach to the CHNA relies on a model developed by the County Health Rankings and Roadmaps and the Robert Wood Johnson Foundation. The graphic that we see is a visual representation of the County Health Rankings model, which incorporates assessment of physical environment, social and economic factors, clinical care, and health behaviors to create a model of community health improvement with a focus on health outcomes, specifically length of life and quality of life. This CHNA is available on the UAB website along with previous iterations of the CHNA completed in 2019 and 2016. Unfortunately, we found that there are two areas of focus that resulted in low rankings. While the intent to create a plan that is feasible and sustainable was mentioned as part of the initial assessment criteria, it was only addressed as UAB providing financial and in-kind resources as part of the action plans. There was no specific indication on how the financial needs would be met or if the projects were truly sustainable for the 3-year period of the plan. Development of a comprehensive measurement and evaluation was mentioned as an upcoming step, but was not addressed thoroughly in the plan as written, bringing that area to a low ranking as well. The intent to develop evaluation measurement shows a commitment to continuous improvement, but is lacking in the CHNA currently. There are objectives and anticipated impacts in each action plan, and a comprehensive measurement and evaluation process has already been planned. However, this is an identified area for improvement with a medium ranking assigned. The goals are not SMART, which means specific, measurable, achievable, relevant, and time-bound, in relation to providing measurable outcomes compared to a baseline rate. The goals specified are broad in scope and qualitative in nature. While they emphasize the importance of comprehensive and strategic planning, they lack concrete, measurable indicators or standards to measure progress and evaluate the effectiveness of the provided implementation strategy. There was an abundance of data included throughout the CHNA. Primary qualitative data was obtained from community member surveys and stakeholder representative interviews. The community survey contained 16 questions regarding health outcomes and behaviors, social determinants of health, and clinical care for Jefferson County and its surrounding areas. Results were compiled and analyzed from nearly 7,000 respondents, which provided valuable insight into the issues of highest importance to the community. A series of 26 one-on-one community leader interviews were conducted by the Alliance to gather feedback from key stakeholders on the health needs and assets of Jefferson County and its surrounding areas. Interview participants included health experts at the state and community levels, as well as local civic leaders. Secondary quantitative data was utilized as well. Apart from citing the United States Census Bureau and the CDC, the assessment does not specifically mention which data sources were already used, aside from indicating extensive primary and secondary data review focused specifically on identified population. Health indicators in the following categories were reviewed: health outcomes, social and economic factors that impact health, health behaviors, access to health care, and disparities. Data relating to COVID-19 impact on Jefferson County was also gathered. The sheer abundance of primary and secondary data, even though the secondary data wasn't fully cited, resulted in a medium quality rating. As it was not clear which secondary data sources were used, we can provide options for alternate data sources that provide existing county-level data. Those include the local public health department to determine local health trends, EHRs to assess patterns in health outcomes and service utilization, and social service and nonprofit organizations to understand social support systems and gaps. The identification and prioritization approach was given a high-quality rating. This was a joint effort involving community partners. The process involved reviewing standards and guidelines, aligning with organizational strengths and priorities, and taking feedback from the community into consideration. UAB Medicine defined identified needs as the health outcomes or related conditions impacting the health status of community members in Jefferson County. UAB Medicine and its community partners, known collectively as the Alliance, then utilized a review of standards and benchmarks to narrow the list of identified needs into significant needs. From there, UAB Medicine prioritized 3 significant needs to address through the 3-year CHNA implementation strategy. UAB Medicine demonstrates its commitment to targeted and strategic health interventions, which are more likely to yield measurable improvements in health outcomes by establishing significant needs based on recognized parameters. Access to healthcare was selected because of the overwhelming identification of the issue by community members as well as key leadership personnel. Mental health was selected because of the COVID-19 pandemic and has highlighted the need and expansion of mental health services available for both the members of the community as well as the healthcare workforce. Chronic disease prevention and management was selected because the management of cancer, diabetes, and heart disease are top priorities for both the community as well as the providers. Now we'll focus on the first two prioritized needs and assess them in more detail. Let's start with a more thorough look at the prioritized need of access to healthcare. The first two areas we assessed for quality and detail both received a high quality rating. Within the prioritized needs assessment summary as seen on the left of your screen, there is a list of community challenges and perceptions to care that would need to be addressed to help meet the goals of the plan. In this instance, lack of transportation, limitation in medical coverage, prescription costs, and undocumented status were the primary community challenges. An action plan/implementation strategy represents where the hospital will focus its community efforts over the next 3 years. The strategy UAB provided highlights the plan objective, target population, collaborators, resources, action steps, and anticipated impact. They utilize the community challenges and perceptions to develop a strategy that matches the needs of the community. A visual of this portion of the document will be shared in the next slide. Let's move to assessing one of the evidence-based action steps UAB opted to implement. This area received a low quality rating since there was an action provided and business owners identified. However, while it's likely these two action steps are evidence-based, there was no supporting documentation or even a more thorough step-by-step plan on how these action steps would be actually carried out. Let's look specifically at the first action step. Provide education on the importance of primary care services. The prioritized needs summary on the previous slide outlines significant data highlights, assets and resources in the local context in relation to the identified access to healthcare gaps within the population. For example, the rate of preventable hospital stays per 100,000 people were 4,558 in Jefferson County, as compared to 5,466 for Alabama and 2,565 for top U.S. performers. A preventable hospital admission is one that many have been avoided, had the condition being managed by a primary care provider in an outpatient setting. Given that the preventable admissions rate is well above the rate for top performers nationally, this data is a great representation of how the community context is relevant to the identified need to focus on primary care access. However, there is little to no literature available with our evidence search that shows an increase in access to healthcare based simply on providing education on the importance of primary care services. As highlighted previously, UAB Medicine's data assessment incorporated significant social determinant of health factors as part of the overall initial assessment. As part of the implementation strategy you see here, UAB opted to target medically underserved adults to increase access and awareness of the importance of primary care services. While there isn't evidence that this method may have benefit, it still attempts to tie the population to the identified intervention. Moving on to the second prioritized area, we opted to assess in more thorough detail. Let's discuss the mental health prioritized needs assessment and implementation strategy. Both areas discussed on this slide received a high quality rating, as with the access to healthcare assessment. The mental health assessment also listed community challenges and perceptions that may impact mental health care utilization in the community. In this instance, stigma around mental health, lack of accessible mental health services and providers, insurance and cost barriers, and limitations on virtual care were identified as barriers. As with the access to healthcare slides, an action plan/implementation strategy was also created for the mental health priority area. A visual of this portion of the document will be shared in the next slide. Within the prioritization summary on the left side of the screen, UAB provided an abundance of data highlights assets and resources in the local context in relation to the identified access to healthcare gaps within the population. For example, the ratio of mental health providers in Jefferson County is 520 to 1, meaning that there is only one mental health provider for 520 people. This is far worse than the top U.S. performers ratio of 290 to 1, but far better than Alabama's state ratio of 920 to 1. Taking the community context information into account, let's look more closely at the first action step in the graphic on the right side of your screen. Expand mental health services within hospital access points, ED, and/or clinics. Given that the community data suggests the lack of mental health providers in Jefferson County, this is an admirable strategy to implement. However, since the implementation strategy was created using the same method as the access to care strategy and did not provide substantiated links or more thorough step-by-step intervention plans, we still rank this as providing low-quality detail. We could assume that maybe UAB was following a recommended intervention from the Commonwealth Fund to provide integrated behavioral health services in a primary care setting. This intervention model provides primary care providers with the diagnostic and treatment tools they need, as well as incorporates the duties of paraprofessionals such as community health workers or peer support specialists. These individuals offer a variety of services such as counseling, care management, social support, and skill building, which contribute to the overall effectiveness of this fully integrated approach to healthcare. Unfortunately, given the lack of detail, we are left to wonder if this was the intent of the intervention or not. As highlighted previously, UAB Medicine's data assessment was deemed high quality, incorporating significant social determinants of health factors as part of the overall initial assessment. As part of the implementation strategy, UAB opted to target medically underserved adults to increase awareness of and resources available to address mental health. Now that we've looked at two of the prioritized areas a little more thoroughly, the question remains, does UAB have the right plans in place to address the identified priorities? Let's review in general terms and then specifically offer improvements to access to healthcare and mental health separately. We provided a high-quality ranking to most of the areas reviewed as part of the 16-point criteria evaluation. Many of the areas provided excellent detail and in-depth explanations, which garnered the result. For example, information about the community to be served, the data, and the social determinant of health charts and available community resources were incredibly helpful in laying the groundwork for the rest of the implementation strategy. However, some high and medium results simply checked the box by including the required information but lacked depth and detail. This is especially true with the descriptions of the strategies. While the interventions are appropriate to the needs identified within the population, there wasn't a detailed plan to carry out those action steps. The interventions lacked depth and detail and presented as generic placeholders. The two strategies were examined as a primary prevention intervention focused on providing education about access to care. Without additional details, it is difficult to understand if this will be provided in the hospital setting once a patient admits or through marketing and social media. It's likely that the second action step for each strategy is tertiary, but it's difficult to assess given the generic phrasing. Each strategy has a second intervention that seeks to either increase access or expand services. Again, this lack of detail lends itself to decision that the interventions and strategy are not well developed. Looking at the access to care implementation strategy, UAB has agreed to partner with hospitals such as Medical West and Interventions St. Vincent, as well as many other local businesses and community centers to provide financial resources and educational resources on primary care services and increase their access. However, they have missed an opportunity within their own school to collaborate with UAB's medical school to have more initiatives for students to go into primary care. While the overall strategy is a step in the right direction, it is missing the key component of encouraging more aspiring physicians to go into primary care. Many healthcare shortages that limit access are due to a dwindling workforce in primary care. As the population grows, there aren't care providers to match this. Another action under this access to healthcare strategy could have been to collaborate with UAB Medical School, a great resources that they have to encourage and have more initiatives for students to go into primary care. This approach will solve the problem in a preventative instead of a reactive way. The mental health implementation strategy provided nearly identical action steps as the access to care strategy. However, we've identified a missed opportunity based on information identified in the prioritization phase that was not carried through to the implementation phase. A large part of increasing community awareness of mental health is addressing the stigma and cultural preferences that already exist. You can't create a new outlook without addressing preconceived ideas and beliefs. Working with cultural groups to address stigmas would have been a great additive. Also, just like the discussed access to healthcare strategy, the mark was missed by not including attracting more providers into the mental health care field. UAB has the strong and unique resource of being a beacon for medical education on both a graduate and undergraduate level. They should incorporate this advantage when identifying strategies and action steps. We've established that UAB is lacking in providing evidence-based strategies as part of their implementation plan. The strategies provided did have links to substantiated and supported interventions within the literature. We are now going to provide a peer-reviewed alternative intervention for each of the two prioritized areas we reviewed previously. Starting with access to healthcare. As a reminder, UAB provided the following two interventions: provide education on the importance of primary care services, and increase access to specialty diagnostic and inpatient care for medically underserved populations through local community partnerships. Lack of transportation was identified as a community barrier in the prioritization assessment. The demographics of Jefferson County also show that 89% of the county is in urban setting. We offered the intervention of setting up mobile health clinics as an innovative strategy to improve healthcare accessibility, particularly for vulnerable populations. These clinics, which can be housed in a variety of vehicles, provide a wide range of services and can be moved easily throughout the service area. Urgent care, primary care, and preventative health care are examples of such services. These mobile units are cost-effective and provide flexible and responsive care customized to the changing health needs of certain demographics. Furthermore, they could change their services to match the evolving health situation. In addition to providing direct healthcare services, mobile health clinics develop partnerships with local agencies. This would allow them to provide a combination of medical and social services, therefore enhancing their impact on community health. This comprehensive approach to healthcare delivery highlights the great potential of mobile health clinics in addressing disparities in healthcare as well as improving overall community health. The mental health implementation strategy offered the following two intervention steps: expand mental health services within the hospital access points and provide mental health education and resources for the community. We proposed that UAB might have planned to offer expanded health services in primary care settings as part of the implementation strategy in our earlier assessment. We do not know if that was an accurate supposition, but still stands as an evidence-based option provided by the Commonwealth Fund. We also proposed another intervention option for the population in which UAB and their partners seek to provide our expand digital mental health interventions. UAB provided data regarding the impact COVID-19 had on the community. The pandemic emphasizes the urgent need for mental health services that can be provided remotely. Digital mental health services, particularly those offering personalized care recommendations, have demonstrated the potential to extend services efficiently. A study examining a cohort of adults receiving care through a digital mental health platform reported significant improvements in depressive symptoms and subjective well-being. This demonstrates the effectiveness of care delivered digitally with the support of a therapist or coach. Additionally, the study emphasized the cost-effectiveness of telecoaching compared to other therapeutic modalities. This highlights the potential of digital platforms in providing accessible and affordable mental health care, thereby addressing a crucial need in the current healthcare landscape. We have given you an in-depth review of UAB Medicine's Community Health Needs Assessment. In general, we feel they provided an excellent background on the health system, the community served, and data and social determinants of health they were seeking to address, as well as the process of prioritizing needs for the community based on input from community programs and community members. Though many of the areas within the CHNA were full of detail, the actual implementation strategy lacked depth and detail sufficient for us to determine that the CHNA was of high quality in its totality. The prioritized areas were relevant to the community-identified needs. However, the interventions did not have substantiated documentation to determine if they were the right steps to take for the intended outcomes. The goals were not SMART and lacked concrete, measurable indicators of standards to measure progress and evaluate the effectiveness of the implementation strategy. The CHNA indicates UAB Medicine will develop a comprehensive measurement and evaluation process for the implementation strategy. They will monitor and evaluate the action plans outlined in this plan for the purpose of reporting and documenting the impact these action plans have on the community. This is indicative that while the implementation strategy in its current iteration does not have clearly defined interventions and goals, UAB Medicine is aware of at least some of the limitations of the report and will take a proactive approach to continuous improvement. Thank you.